Welcome back to our second video in our 5-part series. Today we're going to talk about the old way and the new way. Your treatment's old, not you. So we're going to have old right here, O-L-D, and this is really all the stuff you've probably already tried. So usually when you go see a healthcare professional, a doctor, a physician, a chiropractor, even a lot of physical therapists, first thing they tell you is to rest it. Give it a break, which is actually one of the worst things you can do, especially for a general musculoskeletal problem. Resting doesn't give the tissues the right kind of nutrients they need, and in fact can do even more damage to your entire body. So rest is a big one. But I see ice. I have opinions about ice. In the long term, after we're out of the acute phase of an injury, right after the injury is fresh, ice is a really good pain relieving strategy. But in general, doesn't do what we used to think it does. And then we have painkillers. And so for a lot of us, that might just be our ibuprofen or Tylenol. If we've seen an orthopedist or had surgery, we may have been prescribed narcotics at one point. That goes there. These are the big 3 that I see recommended the most. And sometimes if these fail, then we'll go get some imaging. So an MRI or an X-ray, which will tell us what the pathological tissue is. But the crazy thing about X-ray and MRI is that even though your shoulder's hurting and you go get an image, a picture of it, and we can see maybe you've got a rotator cuff tear, some degree of a rotator cuff tear, you might have an inflamed bursa, bursitis, you might have an AC joint issue, you might have a subacromial impingement syndrome. There can be a lot of things that we'd see on an MRI or even X-ray. But if you took the same imaging of your other shoulder, maybe that one doesn't hurt, or your friend's shoulder who's the same age and done some of the same things in their life as you, they would have very similar findings on their imaging, but they may or may not have pain, which is kind of crazy. And that brings us actually to the modern approach. We're just going to say MOD, modern. And that's when we really start to look at your movement. Movement. Because we know as we age, we're going to have certain degenerative processes happen in our bodies. The shoulder is one big one, especially that tends to have more things show up when we get X-rays and MRIs of it. But the crazy thing is, not everybody who is over 50 who has positive findings on their imaging of their shoulder has pain. And so it comes down, a lot of these issues come down to how we're actually moving the joint. And the shoulder is really cool. It seems really complicated, but really only 3 things need to happen for your arm to go up. And if we look at your arm going up and we can figure out those 3 things, all these other motions can start to fall into place with more motion and less pain. So what are those 3 things? The first one is the arm needs to go up. Arm goes up. If our arm can't initiate the movement, it can't finish the movement. And if our humerus can't raise, there's no sense in looking at the other things. 2, our scapula, our shoulder blade, needs to come up and around your body. We'll just say scap movement. So if you've been to a PT before, a lot of the cookie cutter exercises are a lot of things where we're opening up here, here, trying to get the muscles around our scapula, around our shoulder blade stronger and to start using them better. And those are great. They're very important and can serve a very necessary part of the rehab process. But if that's all we do and we don't actually have somebody apply it back to our movement, we're just getting stronger for the sake of getting stronger, which I'm a fan of, but doesn't necessarily help you get over this hump. The third thing that we need to do is externally rotate. I'm just going to write E R. And that's one of the important parts of the rotator cuff muscles. If you've been in rehab before, they have you do a lot of this, which is great. It's good to make those stronger, but again, it's getting stronger for the sake of getting stronger in a lot of cases. What really matters is as we raise up, our arm goes up, our shoulder blade starts to move, and then right at the top of the motion, we start to externally rotate just a little bit. And that helps clear a part of the bone of the humerus away from a part of the bone in the shoulder blade called your acromion. And if those aren't clear, they start to pinch and start to wear at your supraspinatus tendon, one of your rotator cuff tendons. And that is really probably the second most important thing or most frequent thing that I see in the clinic is addressing external rotation at the top of the range versus only down here. So unless we address all three of these things, we don't really stand a chance in getting over our shoulder issue. And now we do need to get stronger, we do need to make the shoulder more mobile, but a lot of that boils down to being able to do all three of those things as the shoulder goes up.